Welcome to the July 2023 LACNETS educational event. I'm Kavya Velagapudi, Executive Director of LACNETS.
I'm Lisa Yen, Director of Programs and Outreach at LACNETS.
And I'm Heather Davis, the Associate Director of Advocacy and Outreach at LACNETS.
Today's presentation is on surgery, the what, when, and where. A special thank you to our supporters, Ipsen, ITM, Advanced Accelerator Applications, Lantheus, and Tercera. LACNETS stands for Learn, Advocate, Connect, Neuroendocrine Tumor Society. Our name also states the mission of our patient advocacy organization. The LACNETS staff includes Lisa Yen and Heather Davis. The board includes Donna Gavin, who is the sister of LACNETS founder Giovanna Joy Sembesi, and NET patient Mary Dunleavy, who has been living and thriving with NET for 18 years. We're excited to share that LACNETS is partnering with the Carcinoid Cancer Foundation, or CCF, to provide support line assistance and other programs. For more information, visit lacnets.org/supportline. Over to you, Heather.
Thank you, Kavya. After Dr. Eric Liu's presentation, he will be taking your general NET surgical questions. Please note he cannot provide personal recommendations on your specific NET diagnosis. To submit your questions, go to the lacnets.org page or slido.com/lacnets7. Again, that event code is lacnets/7. Before we get started, here are some tech tips for your ideal audio and visual quality. For audio, ensure your volume is unmuted on the webinar broadcast screen. Locate the volume control on your device and increase or reduce the volume as needed. YouTube Live offers a closed captioning feature as well. For video, you may enlarge the webinar broadcast screen by clicking the Expand Screen button located in the bottom right-hand corner. This webinar is being recorded and can be viewed on the LACNETS YouTube channel shortly after the broadcast. Our YouTube channel features over 300 videos. Use our playlist to find webinars on imaging, PRRT, nutrition, liver-directed therapy, PhioPara, our annual conferences, clinical trials, and patient stories. Follow LACNETS on social media. We are on Facebook, Twitter, and Instagram with the handle @LACNETS. And be sure to add us to your safe sender email list. I'd like to remind our audience that LACNETS webinars are created for educational purposes only and do not substitute for medical advice. The views shared in this webinar are the experts' personal opinions. Please contact your medical team with questions or concerns about your individual care or treatment. And now I'll hand it over to Lisa.
Thank you, Heather. Because I am a NET caregiver, I, like you, try to stay informed and engaged, not just about the latest in NET treatments, but also about clinical trials, which often paves the way for future treatments. We're excited to share the launch of our Clinical Trials Guide. Our Clinical Trials Guide is an educational resource that features several key clinical trials for neuroendocrine cancers. You can browse the site by the type of neuroendocrine cancer, such as pancreatic NET, GI NET, lung NET, Viopera, or high-grade neuroendocrine carcinomas. You can also browse by some of the types of treatments, such as PRRT or somatostatin analogs. You can find patient-friendly videos and information about individual trials. We hope this guide will help you better understand various NET clinical trials, and as with all our content, this guide is for educational purposes only, and we encourage you to talk to your doctor about your individual care and treatment. I'm excited to introduce today's speaker, Dr. Eric Liu, who is well known to many of us. Dr. Liu is the surgical director of Rocky Mountain Cancer Center's Neuroendocrine Tumor Center. He is a NET surgeon who specializes in neuroendocrine tumors. He completed a fellowship in Uppsala University in Sweden under Dr. Carl Oberg, who is considered one of the pioneers of neuroendocrine research. You may be aware that Dr. Liu was responsible for establishing the first clinical trial in the United States for the gallium-68 dotatate scan, an important tool in diagnosing patients with neuroendocrine cancers. Those of us who know Dr. Eric Liu know he's passionate and innovative in helping patients, and he cares about collaboration with all in the NET community. And to that end, he co-founded the Healing NET Foundation with NET patient Cindy Lovelace. And the goal is to optimize the care of those with neuroendocrine cancers through the education of and collaboration among physicians, healthcare providers, patients, caregivers, and all in the NET community. Dr. Liu's philosophy is always to treat the whole person and not just the disease. His favorite saying is, "The art of neuroendocrine is not what to do, it is when to do it." He values having the patient in the center of the team approach, and he always tells people that he values the quality of life as highly as the quantity of life. To say that he is well loved in the NET patient community is an understatement. Those of us who have seen his office can see how beloved he is. You will see today why he is so popular in the NET patient community. People love his easygoing nature, his sense of humor, and the way he explains things that can be difficult to understand. Today, Dr. Liu is going to discuss the topic of surgery, something many of us consider during the NET journey. His presentation is titled Surgery, the What, Where, and When. Welcome, Dr. Liu.
Hi, Lisa. Hi, everyone. I hope you're all doing well. Sorry about a little bit of the stuff. So I have a very interesting fact that I just learned yesterday. Apparently, I'm the only person that does this live, and everyone else tapes it first and then displays and answers the questions. So I thought what I should do is, for Rich's purposes, who's the producer of this, I would say 800 times, and then you could edit it out right now, and then you can put it on your video. Anyway, welcome everyone. I hope everyone's doing great. It's actually a beautiful day here in Denver, Colorado, and so we're going to have hopefully a lot of fun with our little gathering here. And a lot of you do know me, and hopefully this is going to be a nice session where we can answer a lot of questions and help people feel more comfortable about what it is that they're going through, because it is hard. I get it. It's hard. It's emotional. It's difficult. How do you know what to do? And having the right person and the right support team around you is so important. And having a group like LACNETS, I didn't even realize they had rebranded, but they're not just LA anymore. I love the fact that they're about advocacy and learning and communicating and sharing. And it's such a powerful group that helps and touches so many people. And I'm glad to be just a very small part of it. So anyway, my task, let me make this very clear from Lisa Yen, was that she wanted me to go into the details of surgery and kind of what that means, because it's such a huge decision point for everyone. Because surgery is and I'll go into it. And of course, if you have any questions, as Heather said, please do me a favor, just don't ask any like personal questions, because I feel very strongly I can't practice internet medicine. I need to get to know you and study your scans, and the devil's in the details. So it's not that I don't want to help you, it's just that I probably can't do a very good job helping you in a Twitter or a thread listing now, right? We should all go on Thread. Did you hear that, Lisa? Make sure you're on Thread now. But my job is to talk about just surgery in general, and hopefully it'll help you kind of think about how to think about this whole process, all right? So surgery, the what, the where, and the when. All right, well, here are today's goals. What, where, when, and hopefully most importantly, you'll see the question is why. Why would you want to do surgery? Something big, something most people really don't understand. And I hate to say it, many of my medical doctor colleagues don't understand either the powers or sometimes the limitations of the surgery. And so this is what we have to think about. But for me, these 4 questions are critical for anything, right? I mean, just living life. But what it is maybe even less important, right? Because that's not your job, that's my job. I need to know what surgery, how we do this, what are the instruments and the machines that we need. Where you do it actually does become a very big question. And we'll kind of talk about that a little bit, because, of course, if you are lucky to have such a opportunity or someplace that you can go nearby, that's fantastic. But not all people have that. And so maybe you don't want to have such a big operation at home if you don't have to emergently. And then when? So Lisa told me I think she could probably give this lecture as well as I can. But the when is very important, because, I tell people all the time, neuroendocrine is a little bit like it's like being on a 12-lane superhighway that goes straight, right? And so you have a lot of runway that you can deal with. And so when you do things is very important as well. The sequencing is very, very important. And of course, being comfortable and prepared for it is very important. But then ultimately, you have to know why you're doing it, because you're making a huge investment. You're taking possibly a huge risk, and it better be worth it. And so those are the things that I want everyone to think about a little bit, so that they can go through that exercise and feel comfortable with their idea. So we're sharing today. This is what we do here at LACNETS. We share and we communicate and we learn and we advocate. So let's share a little bit. This is what I want to share with you today. Let's talk a little bit about the basics of neuroendocrine. I think that's still fair. I'll tell you about my philosophy of neuroendocrine, which is just my philosophy. I claim no more than this is how I feel about it. Now, I do this every day. She's correct. I do this every day. I've seen many, many patients. I've had to fix many problems, and I've had to figure out how to fix these problems. So I'll just tell you how I feel about it. And then hopefully I can help you think about how to make that decision of whether surgery is the right thing. And then you have to think about, who do you trust, right? Who do you trust? Who's going to help you through this process? And I will say this, I'm an Asian father of 3, 16, 14, and 12. So you have to do your homework. That is very important. And then we'll talk about what is the surgery, and then how do you prepare for surgery? So a little bit of empowerment for you. How do you recover from the surgery? And what is it that you really want, right? So if you're going to make an investment in this, what is that return on the investment? Now, I will tell you that I am not perfect, okay? I wish I was. I wish every case I did was totally perfect and everyone did great, but it's not, right? I mean, yes, I do know a lot of things, and I do know how to bail out of things, and what is plan B and plan C and plan D. But sometimes the disease can be brutal, and as much as I wish I could fix everything, I can't always. So I just want to put that out there. So as I tell people all the time, it's good to know what you can do, and it's also really good to know what you can't do. What I'm not going to tell you today is, I'm not going to tell you who will do your surgery. All right. I mean, I'm biased. I would say, look, if I had the opportunity to see and take care of every single neuroendocrine patient in the country, I would love that. But I can't. I just can't, right? So I can't tell you who's going to do it for you. I can't tell you if you should do it or not, because every one of you is very different, right? So whether you do it, if it's appropriate, has to be a discussion between you and your care team and your physician, and hopefully your net specialist. When you will do it is also up to you. How to do it, I'm not going to tell you any of that stuff because it's just details you don't need to know, right? Your surgeon's supposed to know all those things. And I'm not going to tell you where to do it, but I will tell you about whether you think it's worth it to travel and what is it you're trying to gain from it. All right, so let's talk about the basics a little bit. So as you all may or may not know, breathing and eating are very, very complicated processes. You know, I live here a mile high above sea level, and I eat McDonald's and donuts all day long. That's all I do. So between those two things, thank goodness there is a whole system in my body where I don't have to think about it, because I'm sure if I had to think about breathing, I probably would pass out, I'd probably be coughing all the time, and I'd probably be spitting up stuff constantly. And goodness, if I had to think about eating, I'd probably be nauseous, I would probably have abdominal pain constantly, I'd probably have diarrhea constantly, right? Luckily, most of the time, we don't have to think about these things because there are these tiny little cells called neuroendocrine cells that control them for you. Neuro because they're smart, and endocrine because they function through hormones. And we don't really talk about it that much because these little cells are scattered throughout your body, and they do things very quietly. You know, it's just like those little guys who are moving the set in the back of a Taylor Swift concert. Anyone going to the Taylor Swift concert? This guy's going to the Taylor Swift concert. So I'll tell you all about it when I get back. But you know, the little people who are dressed in black and are moving the set around and doing all these amazing things that you'd never see. That's kind of how neuroendocrine is. And so, yes, there are endocrine organs like the thyroid and the pituitary and the adrenal gland. Those are professional organs. But it turns out the largest secretor of the hormone serotonin is actually not your brain, it's actually your intestines, because it's such a huge organ. People don't think of the lung as an endocrine organ. People don't think of the intestines as an endocrine organ, but they're very powerful endocrine organs. And when they work great, you just don't know. And when they don't work well, and I'm sure this applies to a lot of you, you know right away. So these neuroendocrine cells are basically found through the breathing and the digestive tract, and they can secrete lots of hormones. And here are 7 that are probably the most famous, but there are probably 7 of 7,000 hormones that are produced. And so it's, like I told you before, it's really important to know what you know, but it's more important to know what you don't know. So there are probably many hormones that many of you secrete that we just don't measure and can make you feel terrible. And they may come from the neuroendocrine tumor itself, who knows? Now, the interesting thing, thankfully, is that a lot of these tumors express what's called the somatostatin receptor, right? It's a little kind of like lock and key system. So the key is the somatostatin hormone, and the receptor is the lock. So they kind of lock together and they talk to each other. And so we have maximized the utilization of that receptor to help not only treat, but to diagnose patients as well. So thankfully we have that. I mean, if you really think about it, there are so many different cancers that wish they had something target like that. And so we're fortunate to have that. So let me just define some words so that everyone understands what we're talking about. So neuroendocrine tumors, sometimes we call them neuroendocrine neoplasms now, is kind of a very broad term that describes all of these tumors that come from these different organs that control the function through hormones. And they're derived through what we call the diffuse neuroendocrine system, right? Now, you may have heard of the word carcinoid as well, too. Carcinoid is an old term that we used to use. In fact, it was the LA Carcinoid Neuroendocrine Tumor Society, was LACNETS previously. But basically, carcinoids are an older term for any neuroendocrine tumor that comes from a tube. So if it comes from a breathing tube or it comes from a digestive tube, they were just traditionally called carcinoids. But we try to get rid of that term because carcinoid, carries the stigma of it being very benign. And it is not benign. It spreads very fast. And yes, they tend to be slow growing, thankfully. But they're not always slow growing. And they're spread very quickly. They can invade other organs and people can die of it. So these are kind of the newer terms we want to use. So just kind of get that out of the way. Now, the problem is that neuroendocrine tumors are very complicated, right? And so many of you heard me say, how can you possibly make a career out of neuroendocrine? Well, it turns out it's complicated. There are more people who are getting it. I am sure of that. And they come from all over the place. So if you look at this slide right here, this is an old slide. I mean, there are maybe 15 different kinds of neuroendocrine. Each one of these behaves very differently. And then each one of these probably has like 3 different branch points, and each one of those has 3 different branch points. And so by the time you're done with it all, there are probably 150 variations of neuroendocrine, which, to be frankly honest, doesn't even describe it, because each one of you is unique and different, right? So as many neuroendocrine patients as there are is probably as many variations of neuroendocrine as there are. So to find the people who can sniff out all the different versions of neuroendocrine is very few and far between. And as much as I wish you could read it all, you can't. Just can't read it. You have to do it every day, and you have to learn from the people, and you have to figure things out. And sometimes you have to make mistakes and find better ways to do things. And then we have new tools as well. But it's really important to understand that in general, the primary tumor actually dictates the behavior of where it comes. So even if you have a lung neuroendocrine tumor and you get the lung neuroendocrine tumor cut out, but it's in your liver, the behavior, at least in my experience, is driven by where it came from originally. Like, what was the personality of it when it first came out? And you may get one from the pancreas, which will behave differently from the one that come from the small intestine. So that primary source, even when it's removed, still gives me, anyway, maybe not with everyone, but with me, a lot of information on what to expect and what to predict and how things are going to behave. So that's kind of how I feel about neuroendocrine tumors, and why the primary tumor itself still is very important. The problem is it can be a very vague disease, it can be very mysterious, and it can hide for a long time, right? So this is just kind of an imaginary graph made by Dr. Vinick, and he said, well, you can have that primary tumor where it originally started, so let's say your intestines. You can have very vague symptoms, and I know that there are people on this lecture right now who have had symptoms before. No one could figure it out, went to the emergency room, and it was basically just sent back home. And then it spreads, and then you get more symptoms, and then you can even die of it, right, if you're not cared for correctly, or even if you are cared for correctly. And it can take many, many years. So it is a slow chronic disease, which is thankfully different from brain cancer or terrible lung cancer or terrible pancreas cancer, in which you almost can't do anything, right? So you go through the pathway and eventually people die, right? Whereas with neuroendocrine, hopefully we can continue to manage the disease for a long period of time so that people can do well and still live their best life. So this is not a disease without a face, right? There are people who have this now. So everyone knows Dave Thomas. Dave Thomas was taken care of very well. He died of coronary artery disease. He didn't die of his neuroendocrine cancer, which is fantastic. People don't realize that Audrey Hepburn had a variation of neuroendocrine, and she had a lot of abdominal issues. For a long time, this fellow, was hiding the fact that he had neuroendocrine for good reasons, I guess. And he, unfortunately, also passive neuroendocrine, a really brilliant man. But there are more people now. Look, Aretha Franklin, one of the greatest artists in American music, had pancreatic neuroendocrine tumors. And guess what? No one knew what that was, even then and probably still now. And as people come out, right? So this is Congressman Castro from Texas. He was diagnosed with metastatic neuroendocrine recently. And anyone who lives in Los Angeles, you're local there, Maria Menendez also was diagnosed with it as well. So there are just going to be more and more people with it. And so the work that we do to try to spread the word, teach people, have medical professionals have a better understanding of the disease is critical, because it's coming. It's coming. I can't tell you why. I can't tell you where. I can tell you it is all around the world, but I don't know how much it's going to be. So all we can do is just prepare for them and be ready to help as many people as we possibly can. Okay, so let me tell you a little bit about my philosophy of neuroendocrine tumors before we get into the whole surgical portion, because I think it'll kind of help shape and frame how I approach surgery. And despite the fact I tease people about surgery all the time, it is a very powerful tool, but it has to be used in the right hands at the right time, right? So let me tell you about my philosophy. I feel very strongly that these are the two things you must think about. And I know it sounds obvious when I say it, but sometimes when you're in a doctor's office, it can be hard to figure out what is it that you are trying to get out of that visit, right? So am I trying to get an understanding of the disease? And I'm trying to figure out what my options are. Do I just want to leave with a plan, right? I mean, how many times have you left a doctor's appointment without a plan, not even knowing what to do? So if you're going to decide, for example, what treatments to do, you think about these two things. You want to think about the quality of life and then the quantity of life, right? So if I told you, hey, I can keep you alive for 35 years, but you're going to be on the toilet 14 times a day every single day of those 30 years. I think most of you would say that's ridiculous. I don't want to do that. But that actually is what happens. So I tell people all the time, I don't know how long I can keep you alive. I don't know. Only heaven and the good Lord can tell you how long you'll be on this earth. But with every little grain of power that I have, I'm going to try to make your quality of life better. I don't want you to suffer, right? Because I don't know how long I keep you alive. But then if you're not suffering, then I will do my best to keep you alive by controlling things and predicting what might cause your demise. And again, if I'm very lucky and I do my job well, I hope that you'll die of something else, right? And then I've done my job. It's not perfect, but how you feel is extremely important. And when I say how you feel, it's like, how do you feel emotionally? What does it mean to you? Like what psychologically, in your heart, in your gut, what is actually happening? I tell people all the time, if you can't sleep and it worries you horribly and you feel like you can't sit on it and you need to do something about it, that's an important thing. And that should be considered when you decide. It is just as important as if you are having abdominal pain or difficulty breathing or choking or recurrent pneumonia, right? Those are very serious too. But considering all of the things that you have to feel is how you need to come up with your best decisions. So I think of NETs very differently, right? So I think of it as very multifaceted. Of course, you have to control the tumors, right? I mean, that's obvious. And that's what a lot of medical oncologists do, surgical oncologists, they control the tumor. But neuroendocrine is more than that, right? And you know that because a lot of you have these symptoms, right? Your stomach hurts, you're flushing all the time, you're having these weird kind of chronic pains, you're having issues with your digestion, you're having, you name it, right? I mean, all these things can happen. And so if I can't get your symptoms under control, am I really helping your quality of life? And then usually if you're not eating well and you have diarrhea, chances are you're not gaining weight and you're not thriving. So that failure to thrive is also an important portion for me. So getting those symptoms under control is important. And of course, the hormones, right? So the hormones are not prevalent in everyone, but for those of you who have it, I know you can feel it. And it may come on like this, right? You may feel it for 5 or 10 minutes when your heart rate jumps to 150 for no good reason. But that still is affecting your quality of life. And it's not until you get all of these three things kind of under control that you get true comprehensive disease control. So I think of it very differently. And you know what? It may take a long time to get these things under control. Because as you know, that when it comes to neuroendocrine, it is a marathon, not a sprint, right? Again, lung cancer, pancreas cancer, liver cancer, those are sprints because you don't have much time to do things. But neuroendocrine is a long process. I mean, how do I know most of you all these years, right? I've known you so well for all these years. It's because I think about all these things for each and one of you as the turtle kind of crawls off the slide. All right. So you have a lot of options, right? You have surgery, you have the shot, you can do some embolization, you have PRT, that's the hot topic. You have these medicines like everolimus, chemo, Temodar, maybe some more surgery, chemotherapy sometimes, these other medicines like sunitinib, maybe some biologic agents, maybe you go back to bland embolization. Immunotherapy is very hot nowadays. Maybe you put chemo in the embolization. So there, thankfully, are a lot of tools in the toolbox. But when people just float these things to you and like, well, what do you do, right? You have to commit to one of them first, right? And just kind of see how things go. Sometimes even active surveillance is the best decision to make. But when you decide on the therapy, you have to realize that there are a lot of them. They affect each other. Hopefully you can use them in such a way and sequence them in such a way that they help each other. So there's what we call synergistic. But it's tough. It's tough to do. And to ask any general oncologist or any general person, general practitioner to do it is impossible and not fair, right? And so you want someone who can really help guide you through this. And I know this because a lot of people say, well, why didn't they tell me this before? And I was like, well, they don't do this every day. And so when you take all the meals, stick them all together right in the middle of the slide, you see there's a fair chance you're going to see every single one of those at some point. The question is when, how, and in what sequence. So again, great to have lots of tools in the toolbox, right? So let's talk about some of the therapies first. So you have surgery, which is our topic of conversation today. I promise I will get to it at some point. But surgery is what I consider a local regional therapy, right? So if it's kind of in your chest or if it's in your belly, right? So those are the areas I can work on. Then we can give the suppressive hormones like somatostatin analogs. Those are systemic therapies. They go all over your body. So yes, they have side effects because they can affect other parts of your body, but they usually target your symptoms and they target the growth of the tumors. You could have hormone synthesis blockade to help with your symptoms. Those are very targeted right towards the specific hormones that are made. You can have what are called molecularly targeted therapies, which are not specifically designed for neuroendocrine, but they can muck up the works, right? So they have a lot of side effects. Good old chemo, it is systemic, so it goes all through your body. But again, it's not just targeted to the neuroendocrine. So it gives you all kinds of side effects and causes all kinds of problems. And you just hope that you can tolerate the side effects enough so that the poison can kill your cancer or treat your cancer. I can't say kill your cancer. And then hepatic embolization. It's a regional therapy, right? It doesn't do anything for the lymph nodes in your bone, but it's really good for the liver. But then you have this PRRT, peptide receptor radionuclide therapy, which is a really very, very powerful tool to have. It is not only systemic, but it is also targeted. So actually what happens is it goes right to the tumors. Yes, there are side effects. It's not perfect, but the tumors eat the radiation and you get radiation from the inside out into every single one of the tumors. So while maybe the embolization can't treat the lymph nodes, the PRRT can. But I can deliver a lot more bang for your buck with the embolization than I can for the PRRT. But who knows? Things are changing. And as we begin to put all these things together, we may be able to improve outcomes. But again, it's great to have all these tools. Now, my favorite tool, as you all know, is surgery. So I say the first thing you can do is you should probably cut it out, right? As much as you can, cut it out. And then you can goof around a little bit. But you know what? I think you should think about cutting it out again, right? I've operated on some of you multiple times. And then, when the oncologist has nothing left to do, I guess I got to cut it out again, right? So that's what I say. Always think about it. Cut it out, cut it out, cut it out. Now, I'm teasing a little bit because, surgery is not always the right thing to do. But the problem is that it's probably not used enough. It may be not used in the correct way. Why? Because making that decision is very complicated, right? And sometimes it's like, in some cases, like it's easy. Like if you have pancreas cancer, they say, oh, you should just go do surgery. Well, that's not exactly the right thing to do. So how do you make the decision? And is it the right thing to do now? All right, so how do we think through this? Well, okay, let's think back. Just if you make any decision, you're buying your house, you're getting married, you're thinking about getting a new job, or you're going to move. What is it that you want to accomplish? And what is the goal, right? So when it comes to surgery, you want to make a diagnosis sometimes, right? So sometimes the scans are a little bit fuzzy, you can't figure things out, and you have to get in there and figure it out. Okay, well, that's great. But then if you can, if I can cure someone, that would be a goal. And surgery is truly the only therapy that's curative. But I think of it differently. So, because sometimes I want to think about what's going to happen in the future. Can I do surgery to help someone now so they don't become a disaster later? And I know that because I've had to take care of the disasters. I was like, oh my goodness, if only I could have seen you 5 years ago, we wouldn't be in this problem, right? And then, of course, I want you to feel better. So how can I make your symptoms better? And there are a couple ways I can do it, right? Hopefully I can just do what's called a complete resection. Resection means cut out, right? So maybe I can cut it all out. Or even if I can't do that, if I can just kind of get the bulk of the cancer out, maybe you can feel better and we can kind of get you cleaned up a little bit and feel better, right? It's like cleaning out your basement or cleaning out your garage. It's not easy. You've probably been ignoring it for many, many years. But when you get it cleaned out, and even if it's not perfect, you feel better. But ultimately, what we have to decide, just understand that surgery is one therapeutic mode, right? We went through that, but it is one therapeutic mode. But what we have to do is we have to weigh the risks and the benefits, right? Yes, it's one of the modes, but it might be one of the riskiest as well, too. Your benefit may be the greatest, but the risk may be higher. So this is the kind of thing we have to weigh, and we have to figure out if it's the right thing at this time for you. And I tell people, well, it's important as well to kind of think about who do you trust, right? So you're sitting in a doctor's office, you're terrified, you've got this new diagnosis of cancer. Sometimes they don't even have the right diagnosis. Right? So you want to think to yourself, is this the right person to guide you, right? Does this person have the right expertise? Does this person have lots of expertise? Do you feel comfortable just talking to him or her so that at least they can answer your questions and you feel like they have the ability to answer your questions thoroughly? And I would say listen to your instincts. I've had the unfortunate experience of taking care of people who didn't have a great relationship sometimes or didn't feel comfortable. Things happened and it didn't go so well. Right? And it happens to me too. I'm not perfect. But having to fix those things and seeing the kind of relief people have when they meet someone who does this professionally every single day is something to just kind of take into consideration. And then trust the people around you, your family, your support, and what do they think about this? Is someone who really knows what they're doing and that you want to put your trust into. And so I think it's important because you're putting this team together. I mean, would you climb to Mount Everest with someone who'd never climbed to? You wouldn't want me to guide you up Everest, right? You wouldn't even want me to carry your bags, probably. But when it comes to something like neuroendocrine, which is a huge mountain to climb, this I can help you with. Okay, so I tell people all the time, you've got to do your homework, period. That's it. There's no negotiating, all right? So before you do your surgery, you have to do a complete evaluation and workup prior to the operation, all right? And then what I tell people again, don't forget, you do need to do a complete evaluation and you need to do a complete workup before you do your surgery. And in case you forgot, you should do a complete evaluation and workup, right? Don't cut any corners. If someone says, oh, you don't need that scan, there's a fair chance you need that scan, right? And of course, you want to do a complete evaluation and workup. And for those of you who have totally tuned me out, guess what? You got to do a complete evaluation and workup prior to surgery, right? Why? Because you want to measure twice and cut once, right? I say this all the time. Even when I'm in surgery, I will look and I will check. I'll put it down. I will look again and I will check and before I cut these things, right? And this is it. So one of you, I'm sure, is going to find this and send it to me, and I'm going to put it on my wall. Measure twice, cut once. All right, that's your project, Lisa, or anyone on the talk today. Again, it's not rocket science. You know, you should listen to my wife. She tells me all the time I'm not as smart as I think I am. So just common sense is very important. Now, do your homework in all of it. Right? This is what I tell my kids all the time. You got to get the right tests. That can be blood tests. You got to get the right scans. That can be CT, MRI, and the dotted tape PET CT that Lisa had mentioned previously. You want to have all the information. I mean, what's the big deal? You get you get a scan, right? You get more information. Okay, maybe it confirmed what you said. Maybe it shows you something new, right? There's no sweat off your back. Just get it. I always have to have more information than less. And then you want to evaluate all your vital organs, right? You want to get an echocardiogram. Let me just tell you a story. So I did a surgery in a guy just a couple weeks ago. He lives out of state. And when I first met him through Zoom, I said, you know, it's really important that you get an echocardiogram. So he went and asked his doctor. His doctor refused to get it. He said, you don't have symptoms. You can't possibly have, you know, carcinoid heart disease. So we push him. He eventually orders it. And it turned out he had full-blown carcinoid heart disease, and that just because he was strong, he was able to kind of, you know, resist it. But if I had not known that and done some wicked, terrible liver operation, he probably would have died on the table, right? So thankfully, we were able to do that. Then I was able to just do his intestinal operation so that he could eat, save the liver for later. We replaced his valve last week. He just went home yesterday. And we'll come back and deal with his liver later, right? So do your homework and do all of it. And part of your homework may be to go see a neuroendocrine specialist, right? And I'm sorry to sound like a broken record. I just feel very strongly about that. And because you'll hear this, oh, the patient is not a surgical candidate. No way. They can't have surgery. That's not even considered. Well, you got to see the right person to really hear that, right? So I tell people all the time, if you're seeing a general medical oncologist, that's someone who, yes, they know a lot about cancer, but they specialize in giving chemotherapy. That's what they do, right? If you see a medical endocrinologist, they are professionals in giving and replacing hormones. If you see a general surgeon, he or she specializes in fixing gallbladders and hernias, right? I mean, I'm a general surgeon. This is what I do. If you see a surgical oncologist, they do lots of different cancers, and they're probably very talented and very gifted, but there's some small nuances to the neuroendocrine aspect of it. And if you see a hepatobiliary surgeon, they do very complicated things, big liver surgery, big liver transplants, which I certainly can't do, but that's what they do for a living. A neuroendocrine surgeon does neuroendocrine surgery. This is what we do, right? And if you think less of it, it just means you haven't done enough of it. That's all it really means, right? So I've had to figure a bunch of stuff out that no one ever taught me. And I've had to see a lot of patients who were treated by other people like this, and it just was not, I just didn't agree. Let's put it that way. Right? All right, so what is the surgery, right? What do I do every day, right? So here it is. Again, let's think about the philosophy of the surgery. What is the goal, right? Am I trying to control symptoms? Am I trying to improve your quality of life? Absolutely critical. Or am I trying to remove all of the tumors? That would be great. Can I cure you of it? That'd be awesome. Always my goal. Am I trying to shrink and whittle the tumors down, right? So maybe in combination with some of the things the medical oncologist will give you or the nuclear medicine doctor? Or am I trying to prevent complications? So I've definitely had patients where the spouse has found them in a pool of blood in their bed. It's horrifying. It is horrifying. I wish never of any of you had that. But I was like, well, that happened because of XYZ, and we had done XYZ before. This would have never happened, right? So these are things to kind of consider. Or are we just trying to play for a draw, right? Am I just trying to keep things under control, making sure you're feeling well, making sure you're traveling and loving life and doing the things you want to do and eating and sleeping and exercising and enjoying your family and your loved ones? And can I just keep things quiet so that you can live your life? And truthfully, I'm happy to play for a draw, because every day that you're feeling well is a good day, right? It's a good day. All right. So this is what it looks like, and this is what surgery looks like. So this is a small tumor. This is a courtesy of my friend, Dr. Pommier. It's a very, very old slide. But you can see that's what a neuroendocrine tumor from the bowel looks like. It's that little white divot on the left there. It's very unimpressive, right? The problem is they can spread and turn into all these tumors inside your liver. So on the right side is like this brown liver, which should be totally brown, but all these little white spots inside have shot off from the original tumor, the primary tumor, and spread to the liver. Here's just some more examples of them. You can see here, they're pretty classic. They can be like that little, so these are my hands. You can see there's a little divot there, very classic. But sometimes it can be more subtle. It might just be a slight color change. And sometimes it's almost invisible, right? Look at that tiny little white thing. The only reason I knew is because I had to take my fingers and I had to run the intestines and just feel every tiny little speckle of it to find the tumors. And there they were. And this is actually not even my case. This was with my partner, and she's a very good endocrine surgeon, but she couldn't find it. And I said, okay, I'll be down there in a second. And then we found it and we did it, and the patient did very, very well. Very well. And that's it. It's not impressive. It's this little ditzel thing that just kind of comes off the intestine. But that little ditzel thing can cause a lot of problems, right? It can spread to what's called the mesenteric lymph nodes. So you can see it looks like a golf ball, right? That thing right in the middle, those lymph nodes and that support tissue. It's white. I don't know what's white, but it's white. And look how it can kind of shrink down and scar down the intestines and cause all these problems. If it comes from the pancreas, they can be pretty gnarly too. They can be small in the pancreas, or they can just grow right off of the pancreas. Look at that thing, right? So this patient was actually relatively asymptomatic, and she had a CAT scan for a totally different reason. And look how purple and gnarly that thing was. So we were able to get that off. But they cause problems. They cause problems, right? So if you have a neuroendocrine tumor of the bowel, and it's caused what's called a desmoplastic reaction, so scarring down, it can literally wind your intestines into a knot. Imagine trying to eat food through this. Of course you're going to have pain all the time. So this patient happened to have seen a very well-known gastroenterologist, and the only recommendation he could make was to eat a low-fat diet. which is, I mean, I guess is okay for for temporary, trying to get through it. But she needed surgery, so she had her surgery, and now she can eat. Now, we can remove multiple tumors. I know I'm not perfect because it's a microscopic disease, right? So there are tiny little just dandelion seeds throughout there, but I can actually remove a ton of tumors. And I can actually get a complete response in a few hours just by scooping all these tumors out and putting them in the garbage can. So I can do a lot for you in a short amount of time. It's just not perfect. It doesn't last forever. Here's a slide I love to show because this lady was probably about 110 pounds and 5 pounds of her were tumor. So you can see that whole thing on the right side of the screen. That was one big tumor. That was it in this tiny little lady. And then the other ones were tumors too. And you can see I took just a little bit of liver around it. But look at the one in the middle. See that one right there? That was very interesting. It's what's called a cystic neuroendocrine tumor. It's filled with jelly. And the only reason I knew it was neuroendocrine is because she had a gallium dotatate PET CT, and it showed me that the shell was neuroendocrine tumor. So it shows you that even as much as each of you zebras is different, each one of the tumors within you is also different. So I have to think about that. I have to think about each and every single one. Here's another example. This patient came from Houston, Texas, and his tumors were growing, and they wanted to give him chemotherapy. I said, no. You don't need chemotherapy. Let me tell you why your tumors are growing. It turned out that his tumors were little balloons, and they were bleeding into the tumor, and it wasn't that the tumor itself was growing, it's that the balloon in the blood was expanding it and making it look bigger. So we cut them all out, and he is still doing very well and traveling all across the country and living his best life, which makes me so happy. Did I cure him? No, of course I didn't cure him. But he didn't get chemo, and he's still doing great. So I like to show this because this is really what the whole family of tumors looks like. It's a little hard to see, but you can see a tiny little tumor in the primary tumor in the small intestine in the bottom. It's this ball down here. I don't know if I can show the pointer. But there's a little ball there. And then look at all the little balls there. It reminds me of those stickers people put up on the back of their cars with their families, right? You have one big one and a bunch of medium ones and a bunch of small ones. So there are, for whatever reason, quite a huge variation in the way that the neuroendocrine tumors present, even within one person. Can't tell you why. But here's an example, right? So this is a lady who came from my old neighborhood near Washington, D.C., and she had this big tumor in her liver. And everyone said, no, you can't operate on it. You can't do anything. Maybe we can embolize it, and you only have a year to live. Well, she was 38 years old, right? And so that's not something you want to hear. So she came out to see me. She's still alive. And this big thing is now in the garbage can, right? So you can do these things if you talk to the right person who has the experience with these kinds of things. And sometimes they come in other organs too. This is not a Mickey Mouse hat. This is a uterus with two huge ovaries that are completely infiltrated with a tumor, right? So this is not normal. This is not what it looks like anymore. I mean, this is not what it looked like in the beginning. But if it causes you abdominal pain and pelvic pain, for women in this case, these tumors can be upsetting. And just to remove them can do a lot to help them feel better. All right. So the way I kind of think about it is you just have to have done this a lot, right? And so if anyone ever looks at my phone, I have some pictures of my kids, but this is what I have on my phone. And you can see the variations involved. And these are all things that I had to kind of figure out. Maybe you put in a feeding tube. Maybe you take out this organ. Maybe you take out that tumor. Maybe you fix their heart. Maybe you got to fix their gallbladder. Maybe you got to get those tumors out from the mesentery. Maybe it's perforated. I've got to figure out how to fix the perforation because it's leaking. Maybe it's communicating with the bladder. I got to fix that. Maybe the liver is sitting on top of the stomach, so the person can't eat anymore. So I got to get that liver fixed so they can eat. Or maybe it's draped all over their tumor, or maybe it's in their bone, or maybe a pill got stuck inside the tumor, or maybe there's dead bowel. And then you do it over again. Oops. And then you do it over again. And then you do it over again. And you see all the different variations that can arise. And when you see it all over and over and over again is when you can start to really understand what needs to be done, because there are lots of things that can be done. And just because someone says it can't be done doesn't mean it can't be done. Okay. So I hope I didn't give anyone a seizure from those slides, but that's kind of how I feel about it, right? I mean, there are days when I feel just like this, except I don't drink that much coffee. So there's tea at the chai tea on the floor there. But this is how it is, and it can be quite overwhelming. And so people will say, "Oh, well, you have many, many patients who you can take care of." I'm like, yeah, sure, I have many patients, but that's not the point. The point is, for this one person today, this is the most important thing that they may ever do in their life. And so we're going to do the very best job we can, always, right? So one of the questions that people will ask me is, well, should I travel for surgery? Well, it's not perfect, right? It is certainly less convenient than being at home and going to the hospital down the street. The logistics are definitely more complicated. There's no question it's more expensive, because you'll have to have a hotel room, and you'll have to have airplane tickets or train tickets or gas money. The follow-up is certainly harder, right? So we have to kind of call you more often. You have to be more diligent about calling your surgeon from long distance. And if you're here, you won't be at home, right? So it's not like all your family and your friends and your parents can come all the time. And even the physical travel itself may be difficult, right? So sitting in a car for 4 hours may not be great. But I'll just give you an example. I had a patient who lives in Salt Lake City. She went to the cancer center there, and she was told, you can't have surgery. Your only option is hospice. And she said, and they said to her, she told me that, she said, no one in the world will do surgery for you. And she said, that's not true. One person will do surgery for me. And so she came over here, and we got her fixed up, and she can eat now. It's a perfect? No, it's not perfect, right? But she is certainly much better. She's alive, right? And she's certainly doing much better than she was when she was in the hospital. So sometimes it might be worth it to travel, but it's hard to know, right? And so people ask me all the time, well, should I come in and have surgery? It's like, I don't know. How can I possibly know without meeting you and studying the case and understanding if it's the right thing to do? So that's what you have to consider. Okay. Now, another reason that you want to travel is because you want everyone in the hospital to know about neuroendocrine, right? So when people walk in the door, they don't need to know your diagnosis. They just need to know that you're Dr. Lou's patient, right? So you want the physical therapists, you want the OR staff, you want the Department of Radiology, you want, of course, all the nurses, right, who are so well trained and so experienced. And you also want the head of anesthesia and the head of surgery and the administrators to know about neuroendocrine, because in the end, you're the one who is in the middle of it, and you don't want to walk into a hospital with like, you have what, right? If you hear that, you may think again about it, because we're professionals. We do this every day, right? I'm very, very blessed to work with these incredible people. And, Jessica and Amy are in the hospital with me. They've been working with me for 4 or 5 years now. Alejandra's been with me for 5 years. Bethany's been with me for 3 years. Laura and Hannah have been with me for several years. And unfortunately, Perla just left for a new job, and she's moving on, which is great. So our team is changing, but I feel very strongly that you want everyone to understand neuroendocrine, because it's not really that hard. You just have to know it over and over and over again and just see it. Okay, so if you're having surgery, what can you expect, right? So before you have surgery, there are some things that you need to do. First of all, you need to feel comfortable with your medical team, right, in your surgical team. So you have to have a plan. You have to have the person who's going to take care of you. If you're traveling, can your PCP remove your drain and your staples and stuff like that? Can you still be in communication with your surgical team so that if you have a problem, they can at least guide you, right? So that means you need to get educated, right? I know I'm preaching to the choir, so I get it. But you need to know what's going on so that you can feel good. And as far as getting ready for your surgery yourself, stay active. Do the things you want to do, right? Unless you're sick, you're really sick, but as much as you can, stay active. Don't just think you need to rest up for your surgery. That's not true. For those of you who still smoke, stop smoking. Stop smoking, period. All right? I don't care if it's marijuana. I don't care if it's tobacco. You stop smoking, all right? And then continue to eat well, right? Because you want to be well nourished. Now, I'm not saying Doritos, right? But you want to eat well. So that means have protein, have fat, have colors, right? Because that food is going to take care of that DNA, which is going to help heal you during and after your operation. And for some of you who are really sick and just can't eat, this might be the form of nutrition you need, liquid nutrition through your vein. So those are things to consider when you're preparing for surgery, because you just want to be strong. And I get it. Sometimes you have to have emergency surgery. But if you can be strong for your operation, then hopefully things will go well. Now, what happens in the hospital? Well, hopefully you'll have the ERAS protocol. And that's, just so you know, that is not the Taylor Swift tour, which is happening right now. This is early recovery after surgery. That means getting you up, moving around, getting your pain control, feeding you early so that you can recover your bowel function. But that pain control is super critical, right? I mean, we hear all about the opiate pandemic that's going on. Yeah, pandemic, really, it's going on. Epidemic, I guess, that's going on right now. But still, fentanyl is a powerful medication that we can use to help control pain, but it should only be used in the hospital by anesthesiologists and professional doctors. So maybe you get patient-controlled analgesia. Maybe you have an epidural. Maybe we use other medications besides opiates to help control your pain. We need to control your nausea, right? Because if you can't control your nausea, you can't take the medicine. So we have medicines for that. Slowly start to take more food. Get out of bed, move around, right? Your body is designed to be vertical, not horizontal all the time. You want to take big, deep breaths. And I know for a lot of you who've had either chest surgery or belly surgery, that can be difficult. And in our case, we have these weird complications such as carcinoid crisis, right? So we want to make sure that's under control. You want to make sure your hospital knows how to manage it, either prevent it or really manage it when it happens. And then if there are any complications, just be aware that they can happen, right? Because not everyone is so lucky and things can happen of no fault of anyone's. Your operation can go perfectly and you can still have some infection, some blood clot. I mean, hopefully not, but hopefully you won't have like a heart attack or a stroke. But anything can happen. And so you just have to be prepared for that, as long as hopefully you and your team can get you through it. And then what happens when you're at home, right? You need to recover. So if you're, let's say here, you traveled here for your surgery, keep you here for a couple of days, make sure you're okay. We stay in touch, right? We have the phone service, we have email, we have the portal, we have so many ways to communicate nowadays, right? You want to take your medication as prescribed, because I want to make sure that if your pain is not under control, you want it under control so you can do all the things to help you recover better. And then you want to just continually increase your activity. Yes, you don't want to pull another muscle or blow a hernia or something like that, but you want to push your body while you listen to your body, right? So if you need to take a nap, take a nap. But if you're up and you have a little bit of energy, definitely go do something, right? Eat what's comfortable, right? And I know we have these fancy carcinoid diets and things like that, but you want to eat what's comfortable, because if it hurts you, fine, don't eat it, right? Chances are it's not going to be dangerous, but just eat the things that work for you. Take a shower. I mean, I know, yeah, you have a drain, you might have an IV, and you might have incisions, but taking a shower is very, very humanizing, right? And so it makes you feel like a person. And just remember, as independent as you used to be and before you got sick, sometimes we need help. And so sometimes you need to rely on your loved ones. But at the same time, be independent. Do the things you can, but just when you need help, take it and ask for it. But what are you trying to accomplish in the long term, right? Well, hopefully it's relief of symptoms, right? So if you don't feel well and we can make you feel better and live like a regular human being, that's always what we want to do. But just expect to have continued surveillance. Expect to have other treatments. Remember all those things going around in the treatment bubble, right? And they all land in the middle, right on you. Just expect the disease to recur, right? It happens all the time. The problem is it's a microscopic disease. And yes, I can cut things out. I can make your symptoms better. I can set the clock back. But eventually they start to pop up again because they're just tiny little dandelion seeds that have floated out there. But again, if the dandelion seed isn't hurting you, it's not killing you, and it's not making you suffer, then maybe you can live with the disease, right? And of course, you need to always have a long-term relationship with your medical team. Always feel good about that. And sometimes you need to change your team over time, right? Maybe you can't travel to Colorado all the time for your medical care. That's fine. Maybe we can work together, find other ways. Or maybe you don't like me. You want to find someone else. That is okay too. It is most important that you, your family, your loved ones feel comfortable with the team that's taking care of you. But the cool thing is that there's definitely new technology, and you should expect new cool things to come out, because they are. I mean, look, our little Neuroendocrine world has had like a whole bunch of new treatments in the past 10 and 15 years. I mean, I'm not that old, and I've seen a whole bunch of new stuff that I did not learn about when I spent some time over in Sweden. So let me tell you a couple of the new and best things in surgery. Some are old and some are new. There's no question being able to see the tumors is still the best thing that I've ever been able to contribute to this field. And it's not just for you, it's for me, right? It makes my job easier. So you can see here, there's a teeny tiny little lymph node that we found on the dotatate PET CT, right? And when I went to surgery, it was not easy to find, but I found it. And it's only because I had the proper map. And when I first started doing dotatate many, many years ago, a lot of people told me that we didn't need it. There was too much false information and that the Octria scan was good enough. And I said, you are insane. The Octria scan is not good enough. You miss stuff all the time, and I can't see anything. And so this tool has, I hope, helped many, many people not only have better surgery, but have just a better understanding and hopefully better treatments for their disease. We have lots and lots of new toys. So, sorry, here's an example. This is a little bit old, but I have a colleague named Dr. Pommier from the University of Oregon, and he had a patient who he had already done surgery on, but this patient had this persistently elevated hormone. So he sent them all the way to me. I used to live in Nashville, Tennessee. We found this little tumor on the scan, which he hadn't found during surgery, and he took him back to surgery, and he found it right where it was on the scan, and he was very excited. I said, oh, I'm so happy for you. You did a great job. And then he's a big astronomy buff, so he sent me a picture of a transit of Venus across the sun during the eclipse, which I thought was very, very cool. He's a neat guy. But you can see still having the right information, doing your homework is super important, because what do we say? We want to measure twice and cut once. Measure twice, cut once. Now, we do have a lot of new tools, and this is actually a very old slide. I don't use some of these tools anymore because they're so old. But we can do a lot of things to make liver surgery better, safer, and easier, frankly, for me. Right? So here's a little toy that I have. I use all the time. It's called an aqua mantis. It actually allows you to boil water and cut through the liver and tumors. I don't even do this technique anymore. It's just too slow. But it's a great tool to have to destroy and burn tumors, not just through cautery, which is where you fry them, but actually boil them with hot water. Very cool. I use this a lot. It's a hemostatic tool. It's a little kind of almost like a cream. So the liver bleeds a lot, right? It has a lot of blood. But you can put this kind of cream on top of it, which has clotting factors on it, and it helps the body heal and clot so that the bleeding is less. And I've used it, I don't know, thousands of times in the past several years, and it has made the surgery that I do much, much safer because it gets the clot. And I know this is just an animation, but it literally looks like this. I cover it with this special Band-Aid, I peel it off, and that stuff just stops bleeding. It is amazing. It is amazing. It's a wonderful tool to have. Now, all of you have heard about the robot, which is also a wonderful tool, and it's incredible. It's incredible, right? It's an amazing piece of technology. And so this is just obviously a demo, but I sit at a console about 4 or 5 feet away from the patient, and the machine does all the work. And I have an assistant who helps manage the tools and the machine. And you can see it's like having my hands inside there. The machine moves just like this. The wrists move. I can open my hands. I can throw sutures. I couldn't suture previously just like with these sticks laparoscopically. I didn't have that skill set. But this machine allows me to essentially put my hands inside of your body and lets me sew and lets me dissect and lets me do amazing things. Now, not everything can be done this way, right? Sometimes, like I showed you, you still need your fingers inside there to find the tumors. Sometimes the tumor is too big that you can't get out through these little holes, so it's not worth it to do this robot surgery. Sometimes, I just don't feel comfortable. There's no question. I can stop bleeding instantaneously with a clamp and sutures, but I can't do that with the robot because I only have 3 arms, right? So it can be difficult. But in the right hands, it is a fantastic tool. Well, what about nuclear surgery? I think this is so cool, right? One of these days, I am going to be able to shoot laser beams out of my hands. I know. I have great faith in technology. Or heck, just give me a wand that can shoot cool beams out of it. I think my kids would probably prefer that. So, okay, fine. Maybe I'm not a superhero. Maybe I can't shoot laser beams out of my hands, but maybe we can combine nuclear and surgery. So maybe in the future, if the two of them had a baby, that's what we're going to be doing. So we can have this nuclear therapy, which is amazing, not perfect, but amazing. And we can do surgery, not perfect, but still amazing, and put them together to get better results. And it's evolving, right? So you see the surgery is evolving, but you can see even the PRRT is evolving. We have new peptides, so like new guided missiles. We have new isotopes, so even new like nuclear payloads behind it, and kind of this combinations with other types of therapies, which make things better. You can see there are new peptides that are going through clinical trial. In fact, I think a lot of the LACNETS videos describe some of these new products. You can see we actually have new weapons against it. So literally the nuclear payload that sits on it is changing. Traditionally, we use Lutathera. So Lutathera is the beta emitter. So it's a little bit like shooting marbles at the cells. Yes, it beats it up a little bit, but it doesn't make it go away. The newest one we have is an alpha emitter, in which you can take that little, instead of a little marble, you can take a huge bowling ball and beat the cells with it. And then there's gamma emission too. So gamma is just basically light. And so it's not as therapeutic as I wish it could be. So if any of you plan on getting buff like this after your PRT, don't count on it. It's not going to happen. But maybe if you take this nucleus, which is essentially a huge cannonball or whatever you want to describe it, and you throw it through the DNA, maybe you can kill the cells. I'm hopeful because here's an example of a colleague of mine, Dr. Delpasan, who treated and is doing this clinical trial with these alpha particles, this next generation of PRT. It's a patient of ours that we share. He had metastatic neuroendocrine from the lung, and watch, after all his 4 treatments, all of his disease disappeared, and it's still gone after 3 years. It's still gone. It's amazing. Now, it's still under clinical trial. We will find out. I've given it here as well, too, and it seems to work really well. I had a patient who was very symptomatic. We gave her the treatment, and all of her symptoms disappeared the next day. So I don't want to hype it until we have finished studying it, but I'm so hopeful. Maybe more tools to work with. And the clinical trials that are going on right now are this AlphaMedix trial with an isotope called lead-212, and Ray's Bio is coming out with one with actinium-225. So again, lots of neat things coming out. And if we can combine it with other treatments like immunotherapy or chemotherapy or other kinds of radiation or other kinds of medicines, maybe we can make it even better. Right? Now, the one surgical thing, which I think is actually pretty cool, is this thing called histotripsy. You may have heard of it. It's a new machine. It's not FDA approved yet, but they finished the trial. And what it does, it doesn't use heat, it's non-radiation, and it's not even invasive. They use super high powered ultrasound beams to beat up the tissue and kind of mash it up. It's amazing. It's like a ultrasound blender. And so if you fire all these beams, right? So it comes from this device that fires all, like 50 different beams at it. You can actually just kind of shake up the water that's inside there and the air inside there, and you can create bubbles. And watch, as the bubbles continue to disrupt the cells, it just turns it into liquid. It's almost too good to be true. It's almost magical. But I went to Minnesota a couple of weeks ago, where the company is based, and they showed it to me, and I was very impressed, and which makes me very hopeful. So what it does, it creates what's called this histotripsy bubble. Okay, and you can fire the beams in a very, very small place. So that's the only problem. You can only treat very small things. But the computer you can program to go inside, and it can cover a certain field, and it can destroy the tumor based on the parameters that you want. And hopefully it can protect the large blood vessels so it doesn't hurt you too bad, and destroys the little blood vessels. So it's biomechanical. So there's no invasion, right? There's no needles. There's nothing hot. There's no radiation. And who knows, maybe it even preserves antigens that will help your immune system. We'll see. Again, can't make too many claims about it yet, but they're only going to make a few machines, and we're going to get hopefully ours within 6 to 12 months, whenever they get it FDA approved. So if anyone's interested, please let me know. But I'm excited by it, and it's great to see when these scientific breakthroughs really become available. I mean, look, how great would it be for me to just like pop that thing on you, program my computer, watch your tumor dissolve, and then have you go upstairs to your room 15 minutes later. I mean, that would be fantastic. We'll see. Fingers crossed. So there are a lot of neat things that are coming out. But as you all know, and I hope I've conveyed to you, that each one of you is very different, right? Each individual is different. The whole zebra thing makes a lot of sense because not only is it a rare disease, but each one of you has your own individual stripes. And, as much as I can, if I can lead you to water and help you thrive, that would be great. But there's one thing I want you to do: find support. And I know I'm preaching to the choir here, but there's so many neat people and organizations who are trying to help people with neuroendocrine tumors. Again, there's only going to be more of it in the future. So obviously LACNETS is here. You heard about HealingNet, but many wonderful organizations who want to help connect you to the right person and the right care and the right information. So I'm going to take a second, if you're okay with this, just to kind of plug the HealingNet Foundation. As Lisa said, it's a collaborative foundation that we hopefully work with everyone. And we are trying our best to just bring people together to have new ideas and try new things and just share so that we can not only help you, but help our community grow to help the people who are coming. And I actually chose the name HealingNet because I don't think I can cure everyone. But if I can just heal you from your cancer so that you can live with the cancer, I think that would be something that we can do. And so one of the things that we've really worked on is education. And so we've created multiple documents that you can read. So there's a primer about the medicine of the neuroendocrine tumors. There's the patient journey, right? Because it's not just about treatment. It's also about how you live your life. How do you communicate? How do you pay your insurance bills? Who do you choose? How do you manage your symptoms? How do you talk to your family? And those kinds of things. And it's not just me. I'm very, very blessed to work with so many wonderful people who have contributed to all these documents. So if you want to, by all means, go to our website, download them, they're free, and just read through it, and if they can help you, great. Then I've done my job. So thank you very much. And again, I want to let you know that in addition to LACNETS, there are many people out there who want to support and help you because we know it's a difficult journey. We know it's scary. Cancer's going up. And neuroendocrine is definitely going up. And I hope today's session was a beginning of a conversation to help you understand how to make these difficult decisions so that you can feel good about what you're doing. That's it for me. So I think we can go on to questions and answers, Lisa, or anything else that you want to talk about.
Great. Thank you for that very informative presentation. And before we get to questions, look what I happen to have here.
Yay.
As you know, I was one of the authors, and it is dedicated to our founder, Giovanna Joyce and Basie. So this is really lovely. So thank you for mentioning that wonderful tool as well. So we have more than 55 questions. We can't possibly get to them all, but we'll try to get to a few, and we'll probably run a little over since we started a little late, if that's okay with you. Yeah?
Sure.
Okay. Let us know what your timing is. So you talked a little bit about quality of life and how important a lot about quality of life and how important that is to you. So I'm going to start with this quality of life kind of question that comes up frequently. Is it okay to have a glass of wine at night if you've been through liver surgeries and have metastases?
This is what I tell people all the time. It has to be an expensive glass of wine. That's the only thing I say. No, I'm teasing. So, you should always talk to your medical providers about these things. But in general, a single glass of wine is not terrible. And, your liver is usually healthy enough to tolerate it. Because if it wasn't healthy enough to tolerate it, you'd be way sick and you'd have no interest in a glass of wine. So, nothing in excess, everything in moderation. So if you want to have a little bit because it helps your spirit and your quality of life, I'm okay with it.
Yeah, thank you. I know this comes up frequently. Now, you talked about microscopic disease. So this question came up. Dr. Liu, please discuss NET's microtumors and the issues they present when trying to give patients an accurate diagnosis and treatment plan.
Okay, yeah, so this is actually more complicated than probably even the questioner thinks, but the microtumors are difficult. Neuroendocrine is a spectrum of diseases, okay? So it can be very, very indolent, or it can be super angry and just horrifying and deadly. And so the microtumors, usually what happens is when you shoot out the tumors from your primary and they go to the liver or the bone or wherever they go, we can find them, we can see them. But the problem is there are probably hundreds that we can't see. And I know that because I had my pathologist cut into the liver once in a totally normal portion of the liver. And she found a whole bunch of little micro seeds. But you can live with microseeds, right? So it may make you symptomatic. So that means you may need some treatment for your symptoms. But then it also just means that there's a high probability you'll find it again eventually when they grow big enough to find. So there are a lot of things just to consider. But then there are also people who have microscopic, they're not even cancerous, but they can have like little growths inside their lungs, for example, like little neuroendocrine tumors in the lungs. That's called dipneck. We've seen it in the bowel as well, too. And so they may secrete little hormones that make you symptomatic and sick. And so you have to manage the symptoms. It may not be super cancerous, right? Shooting off into your bones and livers, but they can still make you symptomatic. And so I respect how people feel in that quality of life, and I still try to treat all of it.
Yeah, that's a really helpful answer for a complicated question. You talked about all tumors being different and the various stripes, and this is a challenging question. I'm sure you could talk for another hour about this, but starting from the initial diagnosis, how might you sequence surgery versus other treatments for stage 1, 2, 3, and 4 NETs, respectively? And thank you for sharing.
Sure. Yeah, I think I can answer that. So stage 1 and stage 2 just means very localized disease. You just cut it out if you can, right? Just get it out there. If someone's not a good candidate for surgery, well, of course, you can watch it and hopefully it just stays quiet and it's more of a growth than a cancer. Stage 3 means it does have the ability to spread like to the lymph nodes. So you should try to cut that out if you can. And then stage 4 becomes more complicated, especially if they're asymptomatic. So if you're symptomatic, I think it helps to have surgery. Start with some treatments to make your symptoms better, of course. But then if you can get the surgery and get the tumors out or alleviate the blockage or whatever the symptoms are, then you want to do that. And then if you are asymptomatic, you may want to wait a little bit. You may want to see how the tumors behave before starting treatment to have a better understanding. So the problem is everyone's different. And so you just have to think very hard about what you're trying to accomplish with the whole plan.
Yeah, what's your goals, as you said? So when there's a high burden of tumors throughout both lobes of the liver, when would you, if you could explain, when would you, the tumors would or would not be surgically removed?
Well, high is in the eye of the beholder, right? And so I tease my radiologist friends, they can only count to 12 because anything past 12 becomes innumerable. They don't like that joke. But innumerable is a high burden is difficult to define because it can be true. You can have thousands of tiny little ant-like tumors through your liver. Obviously I can't operate on that, right? But you might have like 4 big ones and you might have like 17 little ones, right? I showed you the picture, right? So you could have that and I can pluck maybe a lot of those out. Or maybe I can remove the 7 big ones and we can treat the little ones with embolization and maybe some PRT or medicine or whatever, right? So you can see it takes a lot to manage the garden, and I want to have every tool in my arsenal to manage it. The question is, what are you trying to accomplish, and what are you going to do, and how are you going to sequence them, and how do they go? So that's the problem.
So on the flip side, with small tumors, liver metastases, like say approximately 1.2 centimeters smaller in several areas that are stable with lanreotide, when would you discuss surgery, if at all?
Well, that's an interesting one. So I don't usually do open surgery till they get to be about 3 centimeters, but it depends on where they are. So if they're getting close to blocking something and I want to prevent a complication, then I might bite a little bit earlier. But that's unusual. But if it's in your liver, I mean, who knows? It's a risk and benefit ratio, right? So if the risk is 0 and they drive you insane and you want me to remove them, I mean, that's okay. But if at the same time, if the new technology comes out and maybe I can erase them with my magic eraser, maybe that's the way to go. So you have to weigh the risks and the benefits to decide, because if things are stable in lanreotide and life is good, it's still better than having surgery.
Yeah, I wish we all had those magic erasers. That would be amazing.
Maybe.
Yeah.
Maybe.
So sticking to questions about the liver, what's the benefit of bland or chemoembolization versus a Y90 versus surgery for removal of the tumor or tumors?
Yeah, that's complicated. That's actually that's a very complicated question. So just to back up a little bit. So the embolization is where the interventional radiologist goes with a tiny little catheter tube into your liver and sprays stuff into it. So you can spray tiny little beads, which cut off the blood supply. And then that's called a bland embolization. And so it beats down the tumors that way. You can shoot a little bit of chemo into it, which I actually don't like at all because I don't think it works that well. So I don't have my interventional radiologist do any chemo at all anymore. Or you can fire radiation into it. But the problem is it's not like PRT, which is a targeted radiation. They just spray it. And the issue is in the past, when you sprayed the whole liver with radiation, it would kill the liver very slowly, but it would kill the liver. And I didn't like that because the complication rate, the death rate was very high. Unfortunately, I had many people die of it. But now what we do is you can focus in a very, very small portion and just like really like incinerate some larger tumors without having to do surgery. And then for surgery, it's good, it's fast, it's actually relatively safe now. I can get rid of huge, huge tumors that may not be treated that well by the interventional radiologist. So you may have to do a little bit of both.
Yeah. Like you said, with that picture with all the words coming in the center, maybe doing something, all those things at some point.
Right, because it's still better for me to take it and put it in the garbage can, right? The embolization, the tumor will always be there, except with the Y90. Sometimes you can melt them if it's done correctly. But for surgery, I can just scoop them out and put them in the garbage.
Yeah. Well, let's talk about some maybe treatments around either before or after surgery. Are there any guidelines for chemo before surgery, say maybe in a 1 or 1.5 centimeter non-functioning pancreatic net?
Yeah, that's interesting. So it depends. So if it's just in the pancreas, I'm not really sure the chemo is super helpful unless you want to shrink it. I mean, 1 to 1.5 is pretty small, but to give the chemo beforehand is probably not that helpful. It's a little different than like regular scary pancreas cancer is very different, right? We like to give the chemo to help beat down all those horrifying little things as much as possible beforehand. But for neuroendocrine, it probably doesn't make a huge difference because if they pop up again, which I just told you should almost expect to happen, then you can always treat them with various types of chemo. But giving what we call cytotoxic chemotherapy is not super helpful for small non-functioning pancreatic neuroendocrine tumors.
Yeah, thank you for that. And then what about after surgery? When would someone need to take lanreotide following surgery?
Well, usually if there's remnant disease and you want to just kind of keep it quiet with the lanreotide because the small disease may have demonstrated to be a little more quiet, right? And maybe lanreotide is a wonderful medicine, but the problem is it's weak, right? So the side effects are not that great, but it's not super strong. So if your disease is not that strong, then it's a perfect therapy for it, right? But if your disease is terrible, it's not quite going to cut it, right? So if you have or if you're very symptomatic. So if people still have symptoms from the microscopic disease, which I can't see, I can't find, then lanreotide is still a terrific therapy for helping people live better.
Yeah, quality of life matters. After surgery, if there is an inoperable tumor because it's too close to an artery, what treatment would you recommend next to address it?
Well, you may not need anything. Because if the artery is wide open and it happens to be close to the artery, you may be able to get it. They may live happily next to each other, right? I mean, look, you live in Los Angeles, right? People live very, very close to each other, so they can live close to each other and they may live in harmony. But if you can get it out, it would certainly be nice to get it out. And sometimes, if that artery doesn't feed anything that's super important, you may get away with removing that portion of the artery too. So again, the devil's in the details, and all the information is super important so that you can make the right decision. That's why you have to do all your homework.
Yeah, doing homework matters. Yeah, we're going to be that parent. You're going to be that parent telling us how to do our homeworks. That's the net vitals too that you put up there. Yeah. So this is an interesting question. Are net patients without somatostatin receptors at a disadvantage? This is actually 2 questions. And what are the consequences, like treatment, scans, et cetera, for a net patient that has negative somatostatin receptors?
Yeah. So the answer is yes. So you are at a disadvantage. It's not necessarily that it is more aggressive or necessarily grows any faster. Sometimes they do, sometimes they don't. But it's just the biology of the tumor. What it means is you just have fewer options available to you. If you don't have a receptor, if there's no lock, the key doesn't do anything. But there's still generic medicines that might be able to help, right? There might be the pills, the chemos. external beam radiation therapy, embolization, surgery. Those are still good options. It's just the more targeted ones like the PRT just won't work as well. And the shot may or may not work as well.
Yeah,
Oh, and
let's
then of
talk.
course a dotatate scan is probably not going to be as good. It won't be as good. So just to give you an example, sometimes what happens is people have lung surgery, and lung is very hit or miss. It's maybe like 50-50 whether or not they have receptor, and they'll have the surgery first before they didn't do their homework, right? Either they didn't know what it was, which is okay, I get it, and then they have it removed, and then they discover it's neuroendocrine. Okay, well, now you discover it's neuroendocrine, but I have no idea because you didn't get a dotatate scan whether it has receptors. So I will actually get the specimen, will stain it for the receptor from the surgery to give me a sense of whether the dotatate scan is a useful tool.
Yeah, that's helpful, and a really good point about lung nets. So speaking of, symptoms and also whether or not they need the shots and such, if you could discuss carcinoid syndrome producing multifocal primaries in the small bowel, and when to do exploratory surgery to find and remove them.
That's a complicated question. So what can happen is, like I told you before, you can have multiple like growths, right? And so if someone needs to have surgery, they should have it for a blockage for abdominal pain. But when it comes to, but the problem is many of these things are very small. I didn't show you a picture, or maybe I didn't as a flash through, but they can be very, very, very small. And there can be one that's big that's causing a blockage. So you got to get the one with a blockage out, but you don't necessarily have to get every single one of those little teeny minuscule ones out. But then you can treat them with symptoms, right? So if you have carcinoid syndrome because they're producing them, then you probably need a somatostatin analog, or maybe a drug like telotrestat, Zermelo to block down the serotonin, or even just good old Imodium to help control the symptoms. So you don't necessarily have to go after multifocal, because people who have, in general, not a whole rule, but in general, people who have multifocal neuroendocrine small bowel tumors have a better survival. It grows very slowly.
That's hopeful. And after surgery for terminal ileum net, what do you look for in the pathology report, and what do you do next after surgery?
I don't look for that much, to be frankly honest. I mean, I know what's going on from the scan, from the surgery. They can't really tell me anything I don't know. In fact, when we do our tumor board, which is kind of like a little meeting of all the docs, the pathologist, oh yeah, here's another neuroendocrine tumor. I mean, it's almost becomes bland. So the information that comes from the pathology is not super helpful from the primary tumor. But if you get it from the liver, or you get it from the peritoneum, or you get it from other places, you might want to have some information that can tell you more about how it behaves. So for example, we would look at something called the Ki-67, which is how fast the gas pedal is pushed down and how fast they grow. Some tumors can grow very fast and some can grow very slow. You saw my family photo, right? So if they grow bigger, then hopefully those are the ones that we get out, and you've got the bad ones out, and the little ones can still be pretty well behaved. So that kind of information is very helpful. But from the terminal ileum itself, it's not super helpful. But you'll know about the lymph nodes, you'll know about stuff, but I almost know all that stuff before I even do surgery.
Speaking of what you know before doing surgery, this question comes up a lot about preserving the spleen when you're doing surgery on the pancreas. Can the surgeon tell for sure if the spleen can be preserved prior to the surgery? Say for 2 to 3 centimeter tumors on the tail of the pancreas, or you can generalize it however you like. Or is the decision made intraoperatively?
Well, I can tell you for sure when it cannot be preserved, right? Because it's invaded the veins, it's clotted the veins, it's stuck on the vein, or it's just stuck on the spleen, right? So I can tell you that that's not going to work. But you can't know if you're really going to be able to preserve it until you get there and see if you can peel it off, right? So I do that with the robot. Actually, the robot's really good for that. You can see if you can peel it off and control it. And if you can't control it, then the spleen has to come with it. So the answer is yes and no.
Yeah.
But
and
it's
along
a very
those
technical question. Yeah.
technical, yeah. Along those lines of pancreas surgery, what's the lifestyle like for patients after a distal pancreatectomy? So removing the tail of the pancreas, considering possible issues with the pancreatic enzyme insufficiency, diabetes, fistula infection. Would this affect future liver surgery?
Yeah, all true. All those things can happen. It's a great question. And all those things should be managed by your surgeon and your physician. Hopefully, fistula and infection are just temporary after surgery. Hopefully, the diabetes is not, you'll have known if you have diabetes or not, because if you don't take off too much pancreas, it's actually really great. The problem is sometimes the tumor is right in the middle of the pancreas, and so you take off a bigger chunk of pancreas sometimes. Sometimes you can preserve it, sometimes you can't. And then you lose like some really beautiful pancreas, and so it can make you diabetic. It's true. A lot of people with pancreas surgery don't make enough enzyme to begin with, and so they need some enzyme to support it. But in general, it doesn't affect the liver because it's on the left side of the belly, whereas the liver is on the right side of the belly.
Thank you. Thank you. Grade 3 NET. This is a area that sometimes people feel neglected. If you could discuss grade 3 NET and surgery options versus chemo or other treatment options.
So the grade kind of tells you how fast the disease grows, right? So grade 1, grade 2, grade 3. It's the good, the bad, and the ugly. And so if you have a fast-growing NET, there's a high probability that they may be different, right? And so that might be the most poorly behaved tumor, and maybe you can get that out. You might want to take some chemo because it's more aggressive and see if you can beat down the deadly stuff first, and then with the chemicals, like kill it with the weed killer, and then see if you can dig up the weeds afterwards. So that's difficult to say, and it depends on the biology, depends on the dotatate scan, depends on a lot of stuff. So the options are hopefully always open. But if you have really grade 3 neuroendocrine carcinoma, in which it's all over your body and it's growing rapidly, then the only option is chemo.
Thank you. How important is serotonin level in the diagnosis and in providing insight into the management of small intestinal NET?
Well, again, so no one dies of a serotonin level, just to be totally blunt and obvious. What people die of is feeling terrible from the serotonin. Okay, so the serotonin may or may not, cause the flushing, the diarrhea. It may or may not cause the scarring of the heart. I just suspect it's more complicated than just serotonin. Because if you inject someone with serotonin, they actually don't get diarrhea. So there's something else, or flushing. So there's something else going on, but it definitely contributes to it. Don't get me wrong. I mean, there's a reason why telotrestat works so well for some people, extremely well. So the serotonin is important because it may be a marker for other problems. So we order, for example, 5-HIAA as a urinary and a blood test to see what the breakdown product is, because maybe that'll help give me a sense of if you're going to develop carcinogenic heart disease. And then there are people who have serotonin in which it very much correlates with how they feel, right? So then you have to treat it correctly so they feel right. And there are some people with elevated serotonin levels who are completely asymptomatic. I mean, I know there are people on this talk who have elevated serotonins and don't even know it because they don't feel it. So I'm like, well, I can leave it be. Serotonin definitely has a lot of functions, right? So it's complicated. And so I have not quite figured out if there's a benefit to treating people with elevated serotonins to try to just bring it down for the sake of bringing down the numbers to try to prevent something. I just don't know.
Yeah. Well, you talked about how surgery is a personal decision. If a carcinoid patient has significant metastases and then forgoes surgery, how might this impact their prognosis?
Well, I mean, again, it's when to do it, not what to do, right? So we can definitely watch it. We can see the behavior of it. It is true, if it continues to grow, there could be other complications for it. And so life might be a little bit harder. So maybe the life is harder for the surgeon and you can still kind of get through it. So you may not have to do it tomorrow. So I've had patients before, they said, you have to have surgery tomorrow. I was like, oh, you don't have to have surgery tomorrow, but maybe you'll need it in the next 6 to 12 to 24 months. And so I have patients who I just sit on sometimes. I know I preach it, but the truth of the matter is deciding when to do it is a very personal decision, as we've talked about for the past almost 2 hours now. And you need to be able to feel good about the decision. And if you want to put it off, you can put it off. But the problem is if you do put it off, then you have to watch it probably more carefully to make sure that you don't pass some line in which real problems come along.
Yeah.
So you have to do your homework. You have to do your homework.
Doing your homework. And then this is another interesting question that comes up often. When would you recommend routine gallbladder surgery removal while on lanreotide, or perhaps a wait-and-see approach?
So I never recommend routine gallbladder surgery when you're on a somatostatin analog. And just so everyone knows, it's not just lanreotide. Octreotide is the other one. So lanreotide is called somatuline, and octreotide is called sandostatin. So I don't ever do what we call prophylactic removal of it. I only do it if I'm doing some big surgery inside their liver. The problem is if you have a big surgery in your liver, the thing scars down so much, it can be very difficult to get back to the gallbladder. I've had to do this before. I had to open a patient just to get to her gallbladder because her liver was so scarred down from the previous operation she had. So if you have a little bowel surgery, excuse me, a little pancreas surgery, and I can still get in with my little laparoscope or a robot, then I don't routinely remove it because I can remove a gallbladder in about 25 minutes. So, and they go home the same day. So it's no sweat off my or the patient's back.
Yeah, thank you. This is an interesting question that's come up. You may have heard of this as well. What is your opinion about Signatera's DNA testing, and is it worth doing it?
You mean this? And all these tests? I think I have several hundred Signatera tests in here. I don't know. My gestalt is that it probably is very helpful in certain situations. I found it to be helpful in certain ways, and I found it to be less helpful in certain ways. And I hate to say this, I don't have a research team to sit down and figure it all out, but it's all there. It's all there, and it's all here. And so I don't know the answer to the question. I actually asked Signatera to see if they would help fund a research project, and they had other priorities. So I was like, yeah, it's okay, no problem. Neuroendocrine is still a little field, but I have high hopes, and maybe some better academic institution will do it and let us know for sure.
Yeah. Thank you. How often do you recommend watchful waiting with typical carcinoids in the lung?
All right, so I don't actually call it watchful waiting, just so you know. I call it because you're waiting for something, right? So I just call it active surveillance. You're just watching it. So this is how I do it. This is all I can tell you, right? For a typical, which is a grade 1 neuroendocrine tumor of the lung, I usually do chest CTs every 3 to 6 months, depending on how the pathology looks like and how scared I am, basically. And then if that turns out to be okay, then maybe after a year or two, we can push it out to a year, and then just keep pushing it out and keep pushing it out and keep pushing it out. So that's how I do it. So I don't actually stop watching people for like 15 or 20 years because you never know if it's going to come back. Like I've had people I have a patient, for example. She had surgery when she was 18, right? She's my age, she's 18, and she was told she was cured. Then she came to see me because she had some issue. So I got a dotate scan. She has widely metastatic disease. So admittedly, no one watched her and no one did a correct workup 30 years ago. Okay, fine. That's okay. But it just goes to show you that you can't ever stop watching because you never know what you're going to find. But usually after 10 or 15 years, you're in pretty good shape here.
Yeah. Yeah, thank you. We're just going to take a couple more. This one is interesting. How do you surgically handle NETs adjacent to the heart?
Well, we either leave them in or we cut them out. So I don't know, it flashed by really fast, but there was a picture of an open heart surgery with tubes and stuff into the chest. And so if we have to replace the valve because the valve is broken, we'll cut it out. But if it's just sitting next to the heart, it usually doesn't cause any problems. So I just leave it.
Okay. And, this comes up often, and this is in general, not just liver and pancreas, but do NETs in general have a permanent cure, or do we need to live with them?
Well, if you can cut it out, you can be cured. Any other treatment is no cure. It's just a treatment for it. And if you have them, you can live with them. And that's the whole goal, right? To live with the disease. So hopefully you can die of something else. Now, the problem is it does become a second job, right? So there's a lot of appointments and a lot of scans and a lot of things to do. But what I tell people all the time is, look, it takes me about 35 seconds to figure out what to do, right? So all you can do is worry. So put that burden upon your NET specialist and your Sherpa, have him or her guide you through it, and in between, just live the very best life you possibly can.
Because that's the point, to get back to those things that we enjoy.
I mean, no one knows how long we're on this earth, right? So if you can enjoy the time that you're here, enjoy the time that you're here. Do the things that you want to do, the things that are meaningful to you. If your work is meaningful, do the work. If your family is meaningful, do your family. There's a
So
country song written about that.
that's a perfect segue to the final question. Just in closing, what final words of hope or encouragement would you like to share today with the community?
That's not 55 questions. What's going on with
No,
you, Lisa? Yeah.
you want to go through all of them? There's more.
Yeah, I think people are probably tired of hearing my voice is probably the bigger problem. Well, I just want to tell people that I want you to understand that there are definitely people out there who are working hard to help you. And it's true, it's difficult for you to manage, and there probably is a fair amount of responsibility upon you to find the right care. But as these therapies come out and training comes out, for example, I know for sure that there just are not enough neuroendocrine experts, and their training is very sporadic, right? And so to be trained by someone who doesn't know anything about neuroendocrine, who thinks they know about neuroendocrine, is probably not super helpful. So the Healing Net Foundation is working very hard to try to raise money and organize to develop a teaching program where we can really focus on Neuroendocrine 360, right? Because you can see here, I mean, it's true, I'm a surgeon, but I do a lot of other stuff, right? I give a lot of medicine, a lot of hormones, a lot of testing and stuff like that. So to find someone who wants to do all those things is not so easy. And I'm just, I just like it. I tell people all the time, I think I'm a born internist who just happens to know how to do surgery. Anyway, but taking care of neuroendocrine is like that because people fall through the net, right? The safety net has huge gaps in it, like because people are siloed. And so if you can catch all the people, then you can help them better. And so I really think that as the awareness increases and people understand what neuroendocrine is, that it will be a little more mainstream and that people have more experience and we'll have more tools and we'll have more experts who can take care of you. But the one thing that will never change is that you have to be involved and you have to learn and you have to advocate and you have to communicate. And those are the things that you have to do.
Yeah, what a perfect way to end this really informative and encouraging presentation and educational event. Thank you, Dr. Liu, for all that you do. As you said, you do much more than surgery, and it's all about the patient in the center and getting them back to doing the things that they enjoy so that they don't have to worry. We can put it on you or their net expert.
Right.
And
yeah, true. That's true.
And so
all right, bye guys. Hope you guys have a great weekend. We'll see you later.
Okay, I'm going to send it back to the studio. Back to you, Heather.
Thank you, Dr. Liu, for that enlightening presentation and answering those important questions from our live audience. Educational programs like these are made possible by our supporters, Ipsen, ITM Pharmaceuticals, Advanced Accelerator Applications, Lantheus, Tercera, and by donors like you. Please consider making a donation today at lacnets.org/donate. And a special thank you to our technical director, Rich Tamayo at TVP Live for this high-quality broadcast production. Today's presentation has been recorded and can be viewed on our LACNETS YouTube channel shortly after this broadcast. If you register for today's webinar, you may receive a survey via email. We would greatly appreciate you completing this survey as it helps us with event and fundraising planning. Again, follow us on social media to stay up to date on our upcoming events. Our handle is @LACNETS. Now back to Lisa.
Thank you, Heather. LACNETS is a community of support and resources. We recognize that you are more than your disease, and we aim to support you as a whole person. Find out more about our resources and programs on our website, lacnets.org. LACNETS also has a monthly podcast featuring experts who answer the top 10 questions in their field. Our June episode focuses on pancreatic net. Go to our LACNETS podcast page to check out the episode transcript, resources, the 10 questions we asked the expert, and patient stories. LACNETS offers a virtual wellness retreat twice a year. Our next wellness retreat is August 5th. Registration is now open. Please join us. Our August educational event will be on navigating clinical trials, expectations versus realities, with Timea Altuba from Moffitt Cancer Center. She has been involved in many NET clinical trials, and we hope this will answer many of the questions and concerns you might have about participating in a clinical trial. Please join us in person on Saturday, September 9th for a joint NET education event by LACNETS, the Theopera Alliance, and Dr. Haidira Del Rivero from the National Cancer Institute. We will have two separate tracks, one for LACNETS and one for the Theopera Alliance. You will have the unique opportunity to meet over a dozen NET experts in person from across North America. This event will not be live streamed or recorded. Registration is now open. We hope you will join us. And save the date for Saturday, November 11th for our NET Cancer Day Symposium in Southern California. It will be a celebratory event where we will once again learn through in-person presentations. And I'm excited that our featured guest will be my person, Tom Bajoris, who has been living with NET since 2015. He will be playing his original piano compositions and sharing the stories behind his beautiful music. Thanks again for joining us today. Goodbye and see you August 19th.